All right. Good evening, ladies and gentlemen. I am Dr. Vishakha Kalikar. I'm a laparoscopic surgeon working at Zen Hospital in Mumbai, India. Along with me today will be Dr. Ramana, who will be moderating today's very interesting talks on complex abdominal wall reconstruction and entero-cutaneous fistula, and also on complex GI surgery and abdominal wall. Let me introduce to you Dr. Vedra Augenstein, who is one of our speakers today. She is a very well published expert in hernia surgery and is a laparoscopic AWR surgeon at the Atrium Healthcare Center in North Carolina. I will now hand over to Dr. Ramana to take the proceedings ahead.
Okay, so we also have our experts in the panel, and we have Doron Kopelman, who many of us know. He's from Israel, and he does a lot of complex abdominal wall reconstruction. We have Rod Jacobs from Australia, but Rod has not joined us yet. And we have Dr. Ramesh Punjani, who is the president of the AWR Surgeons Community. So welcome to all of you. And I suppose Dr. Adarsh Chaudhary, our speaker, has not yet managed to log in. So we will not waste time. We will go with Vedra. Are you okay with that, Vedra? Can you start?
Sure, sounds good. Let's see. I'm going to try to share my screen here. Thank you so much for your kind introduction. I appreciate it and the honor here. So let's see, I'm gonna do slideshow. All right, got it. Can you guys see everything?
Perfect.
Perfect. All right, great. So I'll talk a little bit about my practice and complex abdominal wall reconstruction and in the presence of entero-cutaneous fistulas. These are my disclosures, and so, you know, luckily not all of the cases I do are these. I do a lot of, as I was saying, very nice outpatient hernias, but occasionally you do get some patients who have either very large hernias or complex, need some complex abdominal wall reconstruction. No matter how we're treating these patients or how difficult their disease process is, I think some of the common goals which we all have for a successful hernia repair is that we all try to attempt to close the anterior fascia. We use different strategies to minimize infection in the operative field and post-operatively. Another very important thing is obtaining good quality of life for these patients and improving their quality of life from where they start. And some of the other metrics are shortening hospital stay, getting patients to be able to go home and do well at home, minimizing costs in the operating room. And then another thing that many of us who teach younger residents and fellows, I think it's important to be able to perform techniques that are easily reproducible, that we can teach to them, all of our general surgery residents. So when they leave our residency training program, they can actually tackle these cases without actually having to maybe even undergo fellowship. So those are some of the goals that I have. As far as hernias, as you all know, they come in many different flavors and sizes. And certainly these two patients are very different hernias. And there are a lot of different ways to assess patients. Even if you showed that to a kid, you could see that one is more complicated than the other. But we have much more, we have sophisticated ways and apps of actually looking at patients. One of these apps came here from Carolinas Medical Center, Cedar. Basically looking at 500 of our own patients at Carolinas, over 1 million data points. And basically, as any app, it's a mathematical equation. And this one is used to primarily predict wound complications after an open ventral hernia repair. So some of these predictors are smoking, obesity, diabetes, previous hernia repair, ongoing infection, enterotomy, and component separation. And you can see here in these parentheses, gives you the odds ratios. Some of the important ones to point out are hemoglobin A1C of greater than 7.2 is a predictor. So most of our patients, we really try to optimize them and get those numbers under 7.2, as well as some of these other things. Another one to point out is this BMI over 26. Most of our patients, actually in most of our studies, the average BMI for our hernia repairs is well over 30. But this app shows you that even obesity, even greater than BMI 26, increases risks of postoperative complications. So as far as thinking about what kind of meshes to use, traditional recommendations, we have certain things that in low-grade patients and grades 1 and 2, most people will use some type of a synthetic mesh. Then as you get further along, especially as this talk will center on some of these contaminated cases, most people will gravitate towards something non-synthetic, either an absorbable synthetic or a biological mesh. To talk and set the stage for talking about fistulas and reconstruction, I just want to show you a little bit of data on some of the things that predict mesh explantation and mesh infection in the abdominal wall. So this is one of those studies that really is done very well, over 3,000 patients from Dr. Jose Bueno Yedo. And they, in their huge series, they noted that about 2% of patients had a mesh infection. Most of those required a mesh explantation. Some of the predictors of these infections are steroids, urgent repairs, surgical site infection, which you're going to see over and over and know already. But predictors of mesh explantation, you can see that the odds ratio was 5 for an enterotomy. So certainly those things should kind of they should be things that we pay attention to when deciding what type of meshes to use. This is another nice paper from Vivian Sanchez looking at contributing factors and risk factors for mesh infections. And you can see that the risk factors, obesity, COPD, lots of different things we already discussed, and then entero-cutaneous fistulas as well. And then this is another study from Mary Hahn looking at mesh explantation after incisional hernia repair. You can see that the entero-cutaneous fistulas have a hazard ratio of 8.59. So certainly the highest risk of developing a problem and needing a mesh explantation. Some of the others you can see surgical site infection and some of the types of meshes. So a little bit, I'm going to be showing you some other people's data and then showing you some of our data and then cases and kind of tips on what I do and what we do here. So this is one of these studies looking at enterotomies. I think it's really important, especially as we discuss on social media. We discuss lots of different cases, and many times we really don't reference papers and things like that. But for enterotomies, I think it was not very clear to us initially when we were operating on these patients and placing synthetic mesh until we did the study. So in 4,000 cases, there were 75 of these hernias who had enterotomies. So if you look at the breakdown, if they had a mesh in their belly, it was about a 4% chance of having an enterotomy. So when we implanted synthetic mesh, we looked at patients with and without enterotomy, and there was a significant difference in mesh infection and recurrence. So patients who had enterotomies had 21% infections, and then the recurrence rate was 20. And I think the key to this study is this 38-month follow-up, because if you follow these patients, for 6 months to a year, you will probably not see the mesh infections, and you may not see the hernia recurrences associated with this. And as these complications really don't happen very often, you may not even recognize that the patient who developed that was maybe one of these enterotomy patients. Certainly, if you look at any mesh product, and that includes biological and biosynthetic meshes, but especially the synthetics, they will, in their product warning labels, they will tell you to not use these that they're basically obviously contraindicated if there's a mesh infection or if there's an infection of any sort in the field. So that's just about any synthetic product. Want to show a little bit of mesh infection data from our institution where we've taken care of. Last time we actually did the stats on this, it was only about 300 patients attempting salvage in all of the patients. And you can see pretty long-term follow-up there. But most of the patients had some type of antibiotics. You can see that many of them are treated for almost a year with antibiotics prior to any type of surgical procedure. Many had debridements, percutaneous drainages, but the overall salvage in these 300 patients, unfortunately, was pretty low. So only not about 9% of patients, and half of those are on chronic suppression antibiotics. Certain meshes obviously had lower salvage rates. And the reason for this is really outlined nicely in this surgical infections paper from 2016, really discussing from their standpoint what they think the problem is, and the problem being the biofilm, which is very important in chronic infections, which is a nidus for showering bacteria. So a lot of these patients may do well for a while, and then something happens where they're immunocompromised and this infection reappears. What I thought was really interesting in this paper is that they talked about of course, you need to remove the mesh and all the surrounding tissue, but they also discussed that pain may be the only symptom in these patients. And I think certainly the world is experiencing this opioid epidemic, and it's really important to understand that some of these patients who are constantly complaining of pain, it may be not that they're drug seeking, it may actually be because they have an infected large piece of mesh in their belly and may need to have a resection for that reason. So looking at some more data, and this is also going to come hand in hand with some of the other things I'll discuss with management of entero-cutaneous fistula patients. One of our fellows, Angela Cow, did a nice project using the America's Hernia Society Quality Collaborative data. There were 1,900 patients that had a mesh excision in this group. And these are surgeons from all over the United States managing these patients all in very different, unique ways. The patients who had partial mesh excisions in clean, contaminated, and contaminated cases, so the more difficult cases, had a significant increase in complications, surgical site infection, reoperation. So, this is not our data. This is, everybody's data compounded together. But those are, I think, things that are really important when we start talking about fistulas, and if you should leave any mesh in the abdomen or take it all out when you're handling these very complicated patients. In a little bit more of our data, I think what's important to realize is that very often these patients who had mesh fistulas really don't manifest themselves very early. Some of these patients will have some kind of chronic inflammation, and then will develop a true mesh fistula from a lot of times these are intraperitoneal meshes, and mesh excision is required in 100% of these patients in our group as far as managing them. Okay, so switching gears a little bit about so what to do, how do we tackle these hernia patients, and what I do in the office when I see them. I think it's really important to figure out the reason for the fistula, looking at old operative notes, looking at CAT scans and other contrast studies, just to try to really figure out, why this happened in the first place. I think dismissing this to poor surgical technique is probably something that's only going to burn us down the road. And we really need to figure out, is this patient nutritionally optimized? Have we done everything we can to control the wound? Also doing an endoscopy preoperatively to make sure that there's not any kind of obstructive process. Often working with plastic surgeons who may help reconstruct if there's a skin tissue defect. And I think it's also very important to talk to these patients preoperatively at length, because I think mesh fistulas in a setting of hernia are probably some of the hardest cases to reconstruct. So often these patients get referred and they think we have some kind of a magic pill to take care of them, and it just requires quite a lot of preparation and understanding that a lot of these patients may actually not turn out perfectly, and there are certain things that we need to do to get them ready. So looking at a little bit of data, looking at complex abdominal wall reconstruction with these fistula patients. This is a paper from colorectal surgery in 2017. And 233 fistula takedowns, ventral hernias, and this is 16 different studies. So you can see, as expected, the surgical site infection rates about almost 50%, hernia recurrence rate about 24%, which actually is pretty good follow-up of 27 months. But the intercutaneous fistula rate is about 10%. And I'll show some data later that really kind of parallels that. So I think that's if something to take from these when you talk to your patients in the office. I think it's really important to stress that, you may do everything perfectly, but the recurrence rate and the fistula recurrence rate in these patients is significant. So it is something to get them ready for, so they understand that may happen. As far as timing for surgery, I think we need to try to delay surgery as much as possible. 6 months to 12 months after this fistula development is probably a really good time. Obviously, normalizing nutritional markers, and I'll talk a little bit about that, optimizing health status, functionality, smoking. They all need to quit smoking, and managing their diabetes, and really getting to know these patients preoperatively. As far as nutrition, there are a lot of data out there, but what we really have to make sure that some of these patients who are on TPN, et cetera, that they're really optimized nutritionally. And you can really look at a lot of different data points. This is a nice VA study, which looks at 54,000 patients and basically looking at the albumin levels, and albumin levels less than 21 grams per liter were associated with an increased mortality. So I think all of these patients require some kind of nutritional markers testing prior to surgery, either albumin or pre-albumin. I think it's really important, and sometimes you'll be really surprised as far as some of these numbers when they come back. This is the paper that one of my partners, Dr. Miles here, who used to take care of a lot of these fistulas and still does on our acute general surgery service, shared with me. And it was about really looking at some of these micronutrients. And whenever I see a fistula patient now, I actually pull up this paper and I check all these labs on them. So things, such as vitamin A, vitamin D levels, selenium, manganese, zinc, all of these are really important. And what this paper does, it really outlines how to replace these in patients who don't take PO and in TPN, etc. So I really like this paper. And even though this was for AIDS patients, I think it really translates very nicely to any of our intercutaneous fistula patients. And it's a good kind of outline. As far as some of the data looking at some of these supplements preoperatively, this is a paper that examines 17 randomized controlled trials in elective surgery, looking at oral impact. This is 500 milliliters given 5 days prior to surgery. And what they saw that it really decreased infectious complications and length of stay significantly if the patients got this preoperatively. So that's definitely something to consider. Other things that are really important, especially while you're waiting this 6 to 12 months to operate on the patient, is to really have these patients work with a good ostomy nurse and get to know your ostomy nurses at your hospital, who can be extremely helpful from the standpoint of quality of life for these patients, also protecting the skin. So when you do take them to the operating room, you don't have not only a fistula, but also a huge skin problem to deal with. So there are many different ways that negative pressure wound therapy can be used to control these fistulas. And the nurses that we work with here are really wonderful and creative. And I think it takes a very specialized type of a person who really can put in a lot of time, because sometimes they'll change these several times in a day until they really figure out what kind of a fistula device will help maintain a good seal and help these patients. There are also other methods of doing this, and I don't do this personally, but I know that Dr. Pauli, who has spoken at this conference before, does this, but you can also consider this endoscopic stenting, which is very useful in some of these fistula patients to really control the contamination, and this can be helpful to temporize some of the patients prior to their operation. So as far as once you actually have waited and done everything and optimized nutritionally, what are some of the tips and pearls in the operating room? I think the most important thing is minimizing contamination. Basically oversewing any stomas, fistulas prior to prepping the skin and kind of keeping all of that very clean, removing foreign body as we discussed as far as previous meshes, sutures, etc. Other thing that is really important is reestablishing the GI continuity. So doing your anastomosis carefully. And then once you have done those things, I think that's the most important. Once you can take the fistula down and patient does well from that standpoint, that's the #1 goal. But then repair of the hernia, a secondary goal, and hopefully you can do that in one stage procedure. And I'll talk a little bit about data on that. So obviously closing fascia and then considering delayed wound closure to get healing of these wounds. So here's one of my patients that I took care of for a fistula. You can see that she has a pretty large fistula in her mid-abdomen, but also really a lot of atrophic skin around here, which is essentially just scar. So when examining somebody like this and looking at her skin, you can really note that this is going to be a huge soft tissue defect, and you have to be prepared to figure out how you're actually going to mobilize the skin and eventually close that. So in the operating room, I actually did this case was with one of our plastic surgeons, and he wanted to excise all of this skin. As I talked to you about minimizing contamination, in this case, you can see that I oversewed everything prior to the surgery. And then what we do is we really work in the area of the fistula. So we're getting into all of these other planes in the abdomen and mobilizing everything, and then really tackling this fistula last, because very often the rest of the bowel is not going to have these problems. The problem is going to be mostly where the mesh is, where the bowel is attached to the mesh, and you can just leave that till the end and resect it as just one bowel anastomosis, as you can see here in this patient, and really not even get into any type of contamination in that area, except of course your anastomosis. And then once you're done with the reconstruction of the intestine, then you can, if the patient's doing well and healthy and you think you can reconstruct the abdominal wall, you can see there, this was a case where I did a pre-peritoneal repair, used a big, large biologic prosthesis in this contaminated case. She actually had an external oblique release on the left side of her abdomen, but the mesh is pre-peritoneal, and then we can close her fascia here, so she gets a reconstruction, but I don't close her skin at this point because she's going to be in the hospital for about a week, and there's no reason for me to rush into closing her skin. This vac will be changed several times while she's in the hospital. And then on day 5, 6, 7, whenever she's ready to go, we're going to take her to the operating room, debride any skin or subcutaneous tissue that doesn't look good, wash everything out with some type of antibiotic irrigation, and then close her skin at that time. So we do have a little bit of data from our institution, and we actually have more than this, but this is one of the I think we're up to like 120 or so patients now. But just looking at what this delayed skin closure does, I think some people do delayed fascial closure, but I think that's really kind of, it's hard to do that because a lot of times even 24 hours where the patient's fascia is not closed, you may lose some domain on those patients. So I think if you can reconstruct them with something non-synthetic and then just leave the closure to the skin for delaying that, then you may have good outcomes. So for this group of patients, our CEDAR app would have predicted about 70% of them would have had a wound complication, but by delaying the skin closure about 5 days on average, you can see that we really only had 10% of them developed a wound infection. So for this complicated group of patients, I think 10% is a pretty good rate. Just another patient real quickly, this lady had 3 different fistulas. She was on TPN for 7 months, essentially bedbound. You can see from the look of her gown and everything, she really, this was a kind of a terrible fistula to control, completely dominated her life. You can see also the skin looks very thickened down here. So when I saw her in the office, and this was the CAT scan, so most of these patients are not really sick. It's just that they, have this surgical problem that just needs to get taken care of once they're ready. But if you use the CEDAR app on her, and I think if you don't have the CEDAR app, this is a free download from iTunes that really can kind of help you not only kind of optimize your patients, but and think about, look at the risk factors, but it also helps, I think, with patient counseling. So she did have diabetes. She was not a smoker. Previous hernia repair, obviously there is contamination, so those are all yeses here. Her BMI is very high, but she's already been on TPN for 7 months. And if you look here, the CEDAR app predicts 98% risk of developing a wound complication, so really, really high. So took her to the operating room with a plastic surgeon. He essentially excised all of this very thickened skin, circled out little islands of fistulas, and which I'd already closed down with suture, so there's no spillage during the surgery. This was actually just one loop of bowel that needed to be resected that had fistulized in multiple areas. So she only had one bowel resection. We also did a pre-peritoneal repair here, placed a non-synthetic mesh in there, closed the fascia, and then I did a delayed wound closure. And then this is what she looked like post-operatively, just one small area that had not closed. And then this is a post-op CAT scan that you can see that really the mesh is in place, and and she did well from that reconstruction. So there are ways certainly to, I think, get these patients optimized and get them reconstructed in a stepwise fashion. This is a study from Mike Rosen, 5-year clinical experience using biological mesh. You could see that they had wound complications were also very high because these were 25 of these patients had entero-cutaneous fistulas, recurrence rates about 30%. Some of our data using porcine dermal matrix and 280 patients. These are huge defects, 285 centimeters squared, big meshes, about 25 fistulas. And when you look at if you exclude the bridging meshes, we had about a 6% recurrence rate using biologic meshes, single stage repairs. And these are mostly infected mesh, entero-cutaneous fistulas, et cetera. So really kind of high grade patients. Just wanted to show a little bit of a presentation that one of our fellows gave at Southwestern Surgical Congress. So Mike Arnold was a fellow in our lab, and he basically looked at 13 years experience here at Carolinas taking care of patients with mesh fistulas. And just really wanted to see, as you guys know, techniques change a lot, and we're always, we all want long-term outcomes, but we don't stick to the same techniques. So then data always can be very skewed in all different directions. But Mike looked at this 13-year experience. You can see that these patients really had fistulas for quite a long time, and all of them failed salvage. As far as types of infected meshes, most of the meshes you can see are polypropylene meshes, a lot of PTFE, composite, polyester, very small percentage of biologic, and some unknowns. As far as where the infected meshes are, you can see that majority are intraperitoneal, but certainly patients who have preperitoneal meshes also can develop these problems. Sometimes the posterior rectus sheath after it's closed will break down, and the bowel will be rubbing into the mesh, so some of those will fail. As far as the operative results, you can see that these are big defects, 300 centimeters squared, and complete mesh excision was performed in most patients. Lots of component separations. There's the length of stay. These patients stay in the hospital for quite a while. Recurrent fistula, very similar to that paper I showed you before, about 11%. And then looking at partial versus complete mesh excision, I think this is kind of really similar to what Angela Cow, our fellow, found in that America's Hernia Society collaborative paper. And looking at partial mesh excision versus complete, patients' hernia recurrence rate was much higher if they had a partial mesh excision and also recurrent fistula as well. So I think complete mesh excision is something that's really important. And another thing is also using mesh in these patients is also important. Types of new meshes used, you can see that majority of these are not synthetic meshes. Here we use a lot of porcine acellular dermal matrix in these patients who are high risk. Position of the mesh, I think anytime you can get the mesh out of the abdominal cavity, out of the touchwood intestine, so in a preperitoneal or retrorectus fashion, I think it'll be helpful. Doesn't matter what kind of mesh it is. I think most meshes do well, much better in that position. So looking at multi-stage repair versus definitive repair, if you use a biological mesh versus no mesh, you can see that the recurrence rate is significantly lower. Also, abscess formation was also seen much higher in the no mesh group. And what Mike did when he was looking at this group of patients, he wanted to kind of think about what is really the optimal repair for mesh fistulas. Complete mesh excision was one of the important things. If you can close the fascia, use a biological mesh and prevent this patient from developing a wound infection. So using some kind of a delayed wound closure device, then you can really get a good low recurrence rate. And he identified 18 of these type of patients, which had a fairly low hernia recurrence rate overall. So I'm going to stop here with this conclusion. I think it's really important to optimize these patients. Much like any of our hernia patients, we need to optimize them, but even more carefully with fistulas, worry about their nutrition. I think it's important to also note that many of these patients will not undergo stage repair. So if you can reconstruct their hernia at the same time safely, I think that's really important. And then look at all the different types of meshes that are out there and look at the data on them when choosing the prosthetic very carefully and excising all the old meshes, etc. So I'll stop here, and I don't know if you want to do questions now or if we want to go to our next presenter. Thank you.
Thank you, Vedra. That was absolutely phenomenal. I love that talk. So much of experience has been distilled into that 30 minutes. And I think it's better we take the questions together. Dr. Adarsh Chaudhary is our other speaker. I expect he's here. Sir, can you show yourself, please? He's here. Yes, there he is. Can you unmute yourself? All right. So, ladies and gentlemen, Dr. Adarsh Chaudhary really doesn't need an introduction to a large part of the audience. Suffice it to say that he is one of our best loved and best respected enigmatic figures, charismatic figures, not enigmatic, charismatic figures in GI surgery. His surgical work and his lectures are always absorbing. So he's the chairman of the GI surgery program in Medanta in Gurgaon, Delhi. So over to you, Dr. Chaudhary.
Okay, thank you very much. I am a gastro-intestinal surgeon, and most of my practice is cancer surgery. But all of us have some moments in life where things change, and I, till 5 or 7 years back, had no interest in abdominal wall because I used to enter the operation theater once the abdomen was opened, and I used to leave it before it was closed. But then something happened about 5 years back that changed my life. This is a patient who was 50 years old. He had a large liver tumor, and we planned him for a hepatic resection. The tumor was also involving there was a malignant thrombus in the inferior vena cava, so we did a extended right hepatectomy. We replaced his inferior vena cava with a graft. And he also had a solitary metastasis in the DJ flexure, which we excised. And that was the wound which was after surgery. So patient was discharged after 12 days without any complications, and we were very happy. 3 months later, he presented with this incisional hernia. So I closed this defect, and the only repair I knew at that time was to put a big mesh on it. So we put a big mesh on that, we closed the defect, and we were very happy. Few days later, the patient developed a fecal fistula. The whole story changed. A lot of things happened in this patient, and that kind of changed my thinking. And I realized at that time that conquest is easy, but control is not. All these years, I thought that abdominal wall has no relevance, and here we had made a patient a mess just for a small mistake we made. And it made me think as to why was it that this patient developed a complication which was totally avoidable. If you see the history of human errors, most errors are made by individuals when they are either tired, hungry, or sleep deprived. The Bhopal gas tragedy, the Chernobyl accident, both occurred around between 2 a.m. and 4 a.m. when people were sleepy, they were hungry. So that's why mistakes are made. And I realized same happens in major surgeries because everybody changes. But the poor resident who's left in the end to close the abdomen is the one who continues to work. And by the time you leave, he has no interest left in the abdomen, and the abdomen is closed so casually. Possibly that's one of the reasons that hernias form. So we changed a strategy in our department that any surgery which lasts over 6 to 8 hours, the abdomen will be closed by a fresh team. And I'm very happy to say ever since we changed that, we realized this is one of the ways we could decrease the formation of incisional hernias in our departments. So small things, small incremental changes make a lot of difference because residents' aim at that time is to go home and get some sleep because they've been working since morning, and they are not as interested in closing the abdomen, so a fresh team comes. And also, I realized that we need people who are specialized in doing hernia repairs. I knew only one way to repair the hernia, and that's not the way to go about it. There are various ways to repair hernias, and we must have experts to manage these patients. And now I'm very glad that we have a person who's good at managing these things. If we see after major abdominal surgery, hernias occur in about 5 to 40% of patients. And most GI surgeons are oblivious of this. They ignore this. We forget that after laparotomy, a formation of an incisional hernia is a problem. It affects patients' quality of life. They get into complications. They need resurgery. It's a tremendous drain on the economic resources. And majority of these hernias are avoidable. The problem with GI surgeons who do major cancer surgery, me included, is not that we don't know the problem. The fact of the matter is our endpoints are different. We are only concerned about removing the tumor. The problem of the abdominal wall was never an important issue for us. If you take large studies and you study the endpoints, an incisional hernia is rarely an endpoint. I was very happy in the Panther trial, which was published for managing patients of acute pancreatitis by a step-up approach. They included formation of incisional hernia as an endpoint. Otherwise, majority of studies in GI surgery do not have incisional hernia formation as an endpoint, which is actually a sad thing. This is our figures of hernias, because this is really accurate, because most of these patients have cancers, and we do CT scans in these patients to assess recurrence of tumor. And since I got sensitized to this problem, I started looking for formation of incisional hernias. You can see we have a very high incidence of incisional hernias in patients who undergo cancer surgery. Many of them may not be symptomatic, but that's a fact that incisional hernias occur in patients who have cancers for various reasons. So the important question to answer is, are these hernias, development of these hernias, predictable, and are they preventable? We all know that. We've discussed at length the importance of good surgical technique to prevent incisional hernias. There are a lot of articles. We are teaching residents how to do it. We also know that if we decrease the incidence of surgical site infections, we can possibly decrease the formation of incisional hernias. There are some modifiable patient factors like smoking and other factors which, if they are identified before surgery and managed, the incidence of incisional hernias can be decreased. But there are some factors which can't be changed, like the presence of diabetes, presence of cirrhosis, and there's still many unknown factors. And I feel very amused, like one of these patients of ours, he had ulcerative colitis and was on biologicals. And this patient underwent a subtotal colectomy with ileostomy. And interestingly, most gastroenterologists never recognize this fact. They believe that the only thing which matters is saving the colon. And they don't realize that complications like this, when wounds don't heal, the ileostomy you see is totally separate. There is no muscle mass left in these patients. So many of these things are ignored, and we need to understand that drugs have their side effects. So the overall thing which is important is the patient's quality of life. You might save the colon of the patient, but this patient may not live long to tolerate the second surgery. We generally believe that if we have some sort of a scoring system to predict the development of a hernia, it might make sense. No great progress has been made on this, but I like this paper where by using the hazards ratio as points, these authors could bring out a scoring system to predict the development of hernias. And based on this scoring system, patients who were class 1, who had less than 3 points, the chances of development of an incisional hernia were less than 5%, and patients who had a high grade, nearly 50% of them developed an incisional hernia. This is not an ideal scoring system, but at least it's simple, it's practical. So scoring systems can be used with some degree of accuracy to possibly predict the development of an incisional hernia. We generally talk of biomarkers in cancer, in various diseases, to predict the possible development of a disease. In incisional hernia, we do not have a biomarker. We know that there is a deficiency of collagen formation in patients who have incisional hernia, and very little research has been done. There is a product called as advanced glycolization end products, which are potent biomarkers of metabolic and glycemic stress. These end products form cross-links with collagen, and they are supposed to be responsible for diseases like aging, renal failure, and interestingly, they are autofluorescent, and the deposition in the skin reflects the systemic levels. So if you can measure the skin levels of these products, this is probably an expression of the type of collagen. This is just a suggestion. We are trying to do this study with the Indian Institute of Technology. It doesn't take much effort. You only need a way to judge the skin fluorescence. So if we could get some degree of some biomarkers, it might help us to predict the possible development of an incisional hernia. Those of you who are beyond 35 or 40 years of age in this audience should realize that we are losing 1 to 2% of our muscle mass every year. By the time you'll be 55 or 60 years of age, your thigh will be less than 50% of what it was at 30 years. So it makes sense to believe that once you lose muscle mass, there should be an increased chance of formation of an incisional hernia after surgery. We have great interest in sarcopenia as a predictor of outcomes in cancer surgery. And we published, because the problem with most studies in sarcopenia is that there are no comparative values of the same ethnic group of people. Most studies have used standardized values from Canadian citizens or some other citizens. So we published this study where we used Indian data, and we try to assess by taking the psoas muscle area and the psoas muscle density. And recently, when we analyzed our data of sarcopenia in pancreatic cancer, we thought that sarcopenic patients will have a greater incidence of incisional hernias, but we could not prove that. So possibly it shows that we possibly need a larger number of patients, or probably our methods to assess sarcopenia are not proper. We need to improve our methods to assess, because it is intuitive to understand that muscle mass should be reflected in increased formation of incisional hernias, but we have not been able to prove it. One of the ways to understand a complex disease is to have animal models, like we did for portal hypertension, we did for acute pancreatitis. We created animal models, and based on animal models, we could do trials and get some sense of what is happening. The problem with hernias is that the models are very poor, and most studies use male rats, whereas the hernia in human beings, if you have to have an experimental animal, pigs are better models, but most studies have used male rats. And another big problem is that hernia in real life scenario is a chronic defect, whereas in experimental animals, we produce an acute defect. So that is actually not the real life picture. So you really cannot get good answers from animal models. What are the strategies we can do to prevent hernias after abdominal surgery? Yes, it makes sense to have weight loss, more and more use of laparoscopic surgery, possibly nutritional support can work, and there is an interest in prophylactic mesh placement, and there are some newer techniques. This study, which was published in 2018, is an open label study, and it used intraperitoneal mesh in patients who were high risk for developing an incisional hernia. And this study showed that when patients had obesity, male sex, or surgery for neoplastic disease, or previous laparotomy, they were randomized either for a standard closure or to have an intraperitoneal mesh implantation. And this study showed that prophylactic mesh reduced the chances of development of an incisional hernia after laparotomy. But most incisional hernias form in patients who undergo laparotomy in emergency. So is it sensible to put a prophylactic mesh in patients who undergo surgery in emergency? We still do not have an answer to the question, but there is some suggestive evidence that a prophylactic mesh might be useful in some patients. We haven't really decided what are those group of patients, and possibly an intraperitoneal technique is better. But we should remember that implantation of the mesh is associated with an increased chance of surgical site infection. These patients may have seromas. We know that when you put a mesh, there is more pain, and there's always a potential for developing entero-cutaneous fistulae because of mesh. So prophylactic mesh reinforcement in laparotomy sounds promising, but you still cannot say it is the standard of care. Can we do something experimental? There have been studies where you produce temporary paralysis of muscles by injecting Botox, and in experimental animals, you take the tension away from the linea alba, And in this study, the chances of incisional hernia were decreased. So if you can modify the vectors of force in some supporting muscles, possibly the chances of incisional hernia development after surgery can be decreased. Like I told you that we have great interest in abdominal cancer, and when patients develop ventral hernias following surgery for GI cancer, there are a lot of problems. Many times they have to have interruption in their chemotherapy and radiation, which affects their lifestyle, their quality of life. And many of these patients have poor general condition. They cannot undergo surgery. They may have advanced or recurrent disease. They are reluctant, and there are cost issues. This is one of our patients who had cancer colon and has got a large incisional hernia, but there is also omental metastasis. So it's an ethical question. What should we do to this patient? We know that she will not tolerate surgery, but her hernia is causing a lot of problems. So these patients are sometimes very difficult to manage and really do not know what is the right answer. One of the biggest problems for GI surgeons is the problem of hernias with stomas. I've had a great interest in ulcerative colitis, and earlier when we used to do permanent ileostomies in patients, trust me, 100% patients had problem with the ileostomy. They'll come later after 5 years, 10 years, 15 years with some degree of problem with the ileostomy. And we have problems with parastomal hernias, and we do a lot of surgery for cancer rectum, and these days nearly everybody has a diverting stoma before an anterior resection, and there's always a problem of developing a hernia after stoma closure. Our experience suggests that we will possibly put a prophylactic mesh during stoma closure in patients who are beyond 70 years, in whom stoma has been there for more than 6 months, stoma constructed in emergency, and in patients who receive biologicals. There's so much of muscle damage. We believe possibly a prophylactic mesh placement in these patients makes sense. Most of these patients have a mesh placed during Wurzel. There is some belief that even a mesh can be placed at the time of construction of the stoma, with the philosophy that if you place a mesh at the time the stoma is constructed, it can decrease the formation of a parastromal hernia. But one must remember that if the stoma has to be taken down, then it makes stoma closure a problem. For GI surgeons, difficult abdominal closure comes in 2 ways. One is if you have a complex disease, and second, if we do a complex GI surgery. Open abdomen is a big problem for us. Fortunately, this is a photograph about 10 years back when we realized there was what is called as the bandwagon effect, when everybody was giving a lot of fluids to patients at acute pancreatitis. There was a belief that if you give too much of fluid in the early phase of acute pancreatitis, you can reverse the development of pancreatic necrosis. It did not happen, but we had a lot of patients who had abdominal compartment syndrome, which was a problem. But today, we rarely do open abdomen. The few indications we do is in a condition like this, where we have to do a damage control surgery in patients who have abdominal trauma, and patients who are managed in the rural setting are many times referred to us with something like a Bogota bag, which is a good way to manage these patients in the early phase because it preserves the body heat, it prevents desiccation of the intestines, but the problem is that the wound edges are grossly retracted and the secretions cannot be drained. So Bogota bag is a good way to manage patients in the rural setting, but the problem with these is that it makes subsequent abdominal closure very difficult. So many times patients are referred to us with a big tension sutures. I know tension sutures are not very liked because they cause pain and they really do not prevent incisional hernias, but they really tide over the crisis. So they definitely decrease abdominal wall compliance, but as a makeshift arrangement, I think tension sutures can sometimes be used. There are a lot of unanswered questions in open abdomen. How long can the abdomen be left open? At least it's our experience that if you cannot close the abdomen within a week or 8-9 days, then the complications and the mortality in these patients is very high. And the best technique possibly today to manage the closure of the wound is possibly to use a vac, because the vacuum assisted devices are the best, because they do not cause retraction of the wound edges. Earlier, we used to use various techniques like using towel clips or suturing or putting a mesh. Mesh was a good way, but it was associated with formation of entero-cutaneous fistulae. But now most of these patients are managed by using a vac. We've already had a beautiful talk on the management of entero-cutaneous fistulae. Interestingly, we get a lot of patients referred from the Middle East to our hospital with blast injuries, and various sort of entero-cutaneous fistulae come. And our emphasis in these patients is to do various innovative techniques to buy time, to maintain nutrition, to bring the wound to this level. And then, trust me, the laparotomy in these patients takes time. Many times the anatomy is not clear. So when laparotomy is done in these patients, our incidence, at that time, abdominal wall is not that of a concern, at least in our setup. And the interesting part of it is we always take a lot of emphasis to put a diagram as to what was the pre-op anatomy and what the post-op anatomy, because sometimes it's so complicated. If the patient goes somewhere else, at least the operating surgeon should know what is happening inside the abdomen. We also create abdominal defects by a surgery. Like this is a large desmoid, a patient who came from Uzbekistan. We did a wide excision, and with the help of the plastic surgery people, we put the omentum and they put a graft on that. So getting a plastic surgeon is a great help. Like this patient had a large tumor, and after excision, it produced such a big defect. And when you get in a rich plastic surgeon, it converts into such a nice defect. So it's very good if you have a plastic surgeon hand to manage this patient. This is a young girl who had a bullet injury into her abdomen. She had a liver injury, and she had hemophilia. We did angioembolization. She had liver abscess. So once we controlled the intra-abdominal sepsis, the sepsis was caused by the wound. So we used to debride the wound regularly. We got our plastic surgeons with us. They put a graft on this defect. And then she developed a hernia. They put 2 expanders into her, and subsequently they did a repair. And that's the end result of the surgery in this patient. So over years, I've realized that I may be certified to do complex GI surgery, but I'm not qualified to do abdominal wall reconstruction. And one of the best things is I know my flaws. So now we have a surgeon with us who's experienced in managing the abdominal wall defects. And that's what we need to understand, that this is a team game. And the areas of research to my mind is to one of we are looking at this that does prehabilitation, which means before the patients are taken up for surgery, we put them on aggressive nutritional support. Will it decrease the chances of incisional hernias? Patients who have diseases like rectal prolapse, which possibly have a deficiency of collagen in them, if we study their specimens, can we find out some ways to assess the collagen pattern in these patients? Better define indications of prophylactic mesh placement. And I'm very, very concerned with how we make our stomas, because parastomal hernias, problems of permanent ileostomies are so common, and they severely impact the patients of quality of life. So over years, I've realized that I thought I'm the hero when I used to do big surgeries and I used to feel happy, but now I think my big surgery has no relevance. What is most important is what the patient feels about it. And I used to ignore the abdominal wall. So now I have a heightened sensitivity to it. And I think an abdominal wall reconstruction really matters to the patient, and a GI surgeon should take a lot of effort in taking care of that part. Thank you very much for your time.
You can stop sharing your screen. So in the meanwhile, thank you so much for yet another phenomenal talk. I think we can stop counting the number of great talks that you've been delivering, like one of India's best batsmen. So please stand by for discussions.
All right. Thank you so much, Dr. Chaudhary and Dr. Vedra, for such wonderful talks, especially for people, surgeons like me who are just starting work. These talks were very, very enlightening and very useful.
I think we lost Vishakha. I think some internet problem. Okay, so if you come in, Vishakha, then let me know. Otherwise, let's ask our experts to sum up their thoughts about this entire subject and any specific comments that you may have. Let's start with Ramesh Punjani.
Yeah, I think both the talks were fantastic. Vedra's experience in entero-cutaneous fistula is, first of all, we don't see so often in private practice, but she has got a volume of experience, and very nicely she said that we don't have to rush to the surgery at least from 6 to 12 months after the creation of the fistula. You have to manage the fistula well, improve the skin condition, nutritional status, go to the pre-operative note. So all those points which she said, in fact, I took a lot of screenshots from you, Vedra, and I'm going to read that at leisure. But I think that's what is important. And Adarsh, actually, he said the importance of abdominal wall reconstruction. And we, all of us, have seen that we do get up all these cases mostly done by the GI surgeons. Adarsh is an exception, but not that most of the surgeons, they are not too good, or they are not very sincere at closing the abdomen. So it's very important that we prevent this kind of hernias. And if at all we get, then we must pass on to a people who know and do it better. I think those are the few things which others said were really good. And they have covered both of them this topic very well.
Vishakha.
Yeah, all right. Thank you, Dr. Punjani. Dr. Jacobs, can we have your thoughts on an open abdomen, please?
You have to unmute.
You'll have to
You have to
unmute
unmute
yourself, Dr. Jacob.
Rookie error.
Yeah, I can't sign in and I can't unmute myself. Look, if you'll indulge me, I've got actually a couple of slides I can show you on the open abdomen. I'm interested in Dr. Chaudhary's the fact that they've sort of given up using dynamic closure. I'm a big fan of getting the abdomen closed pretty quickly, and it's pretty rare that you can't get it together within a week to 10 days. And we know that if you do that, then your outcomes are much better. One of the problems with leaving the open abdomen is you then finish up with a much larger defect and a huge hernia, which is much more difficult to deal with. And it's pretty uncommon that you can't actually get the abdomen back together, especially if you use a combination of dynamic closure, negative pressure wound treatments, and Botox. We're big putters in of Botox early on. I can run a couple of slides if you're happy for me to do that.
Yeah.
I'll need to share my screen, obviously.
Vedra would need to go, so you'll take like 5 minutes?
Yeah, 2 minutes, 2-3 minutes.
Yeah, cool, no problem.
So how do I get to share my screen? Here we go. So just quickly, some disclosures. I use a lot of product, but so we saw earlier on various ways of dealing with things like fistulae, and you have to be innovative. And I agree with Vedra that the nurses are fantastic at developing ways of isolating the fistula. So you can see here that the top is a small bowel fistula, and this is a case where we originally tried using the Alexis wound retractor very well, but eventually got this system working with a donut that you can make out of black foam and tegaderm dressings and lots of Eakins paste, and then that. Now the problem is that sometimes you get this sort of situation when you've got the wound to granulate up, and so you're not left with much of a problem, but often it looks something like this. or worse, if you don't get the fascial edges closed. And so there's a lot of expertise that suggests that dynamic closure, either using the commercially available things such as a AWR in combination with negative pressure treatment. We don't use the AWR much. We use the old-fashioned proline mesh with resection and closure. We put Botox in early on, usually at their first laparotomy or second laparotomy, either in theatre or in ICU. And so you can see here that there's an Adthera dressing underneath, and we sew the mesh to the edges, wrapping it around like a pledget so that it doesn't macerate the edge of the wound. And then we just serially excise it and close it and eventually get something like that. And so I think Dr. Chaudhary's comment before was good. If yes, I agree.
The problem. It's overrated. We should avoid doing it as possible. I think the lesser you do it, the better it is. You agree?
Absolutely. I think that the indications for doing it are very infrequent these days.
Very infrequent.
Okay.
All right. Can we have Dr. Kopelman, his thoughts on entero-cutaneous fistula and abdominal wall reconstruction?
Yes, of course. I must tell you that, first of all, I agree that both these talks were excellent. And actually, they covered almost every aspect of dealing with major abdominal wall reconstruction. Both speakers mentioned prevention, aspects of proper preparation towards repair, the abdominal wall reconstruction, different techniques, different types of patients, and different attitudes towards postoperative care. So almost all aspects were covered. And it seems that both speakers have a lot of experience in dealing with such problems. And what is obvious, I think, that nowadays in this event and in others is the changing awareness of this issue of abdominal wall reconstruction. The awareness is changing. I believe that, I know that 20, 25, even more years ago, didn't realize that this is a separate, needs separate expertise and unique expertise in this field of abdominal wall reconstruction. Nowadays, this awareness is more and more prevalent, and we can, I think, most countries are societies that deal with these issues of abdominal wall reconstruction. And more people are less ashamed of choosing this field as their field of expertise, because it used to be considered something that is less important, less significant than dealing with huge tumors or other surgical fields, subspecialties, etc.
Thank you, Doron. I'll just pick Vedra's mind about something that I've been thinking of. Your data is based on on the use of biologics, and I'm talking about these class 3 kind of wounds. In the use of these biologics, my question is, if you look at data coming from Nowitzki or coming from the Cleveland Clinic group, in the use of synthetic meshes in contaminated settings, the results have shown substantial benefit in the use of synthetic meshes, at least, shall we say, at least a reasonable fee in the use of synthetic meshes in this setting. And if you read the Nowitzki paper, one almost gets the feeling that biologics are completely useless. What is your take on this entire controversy?
Yeah, I think, both of the surgeons you mentioned, and if you want to add the Alfie Carbonell data as well, because they kind of started the whole use of, or kind of revived the use of synthetic mesh in contaminated spaces. I think you just have to follow these patients long-term. If you just have 1 to 2 year follow-up on these cases, that's not going to be long enough, because most infections don't even manifest themselves for well over a year. So I think those are the things that we really need to follow up. I mean, I know that Dr. Rosen has a study ongoing looking at synthetic versus biologic. So I'm interested to see in what's going to, come out of that data set. But, I think Dr. Nowitzki also used to use a lot of from going from an area where he used to do a lot of open, big abdominal wall reconstructions to now where he does mostly robotic, non-contaminated cases, and same with Dr. Belyansky. So I think maybe in his practice he doesn't need to use as much biological mesh. But I think most people in general, when doing these big reconstructions, putting a synthetic mesh is probably, you just need to be very. And if you're going to do it, you need to talk to the patients and document it, because it is completely contraindicated. I mean, here in the US, people get sued over that all the time. And if you have it well documented that you're using that product against, the indications, and something happens, then I think it's important. Or if you're doing it as part of an IRB study. So yeah, I think the data on biologics, I think most people use biologics in the worst possible cases where nothing's going to work. So, but if you look at biologics in clean cases, they actually do very well, So anyway, but long answer.
Yeah, and another
Vedra, yeah, I've got a question for Vedra. Okay. About staged repairs. As compared to doing them in one go, what are your thoughts there? If, for example, you use Botox and were able to get the fascia closed, would you then be more inclined to come back another day to synthetic mesh rather than using a biologic?
Yeah, so I think, that's a great question. And we know data that if you primary closure, it's going to be 90% of those patients are going to come back. The problem is that those are not always going to be simple hernias next time. And when you make an enterotomy, once again, you're facing contamination. And a lot of those patients, once they've had their GI tract they don't want another surgery. So from quality of life standpoint, I think if you can reconstruct them in cases, and then you should find another day, as Dr. Jacobs said, use Botox and other things to, but hopefully a synthetic mesh if it's a clean case.
Yeah, Vedra, I had a corollary question to my previous one on the use of biologics in these contaminated settings. You use these biologic meshes in the preperitoneal plane. I think your school of thought is predominantly working in that plane. Now, my question is, when these patients come back with a recurrence, then do you go back into the same plane? How do you approach recurrences with these?
You definitely can. I mean, some of the hardest cases that I've done have been the mesh infections from us here, because we use such huge meshes in that plane. So getting a 50 by 50 centimeter piece of mesh, which obviously it shrinks a lot, but getting that out of all of those planes is hard, but you can still mobilize the peritoneum very well. You can use the omentum and drape that and suture that to the peritoneum, but just really a lot of different tricks to getting back into that space. So yeah, I think you certainly can. And if you have another mesh and you're not going in there for contamination, like a biological mesh, that also, you can use that as your peritoneum.
Vishakha.
Yeah. Dr. Vedra, I have two questions for you. One is, what do you do in situations with an entero-cutaneous fistula, a messy one, and when there is no availability of a vac, how would you then proceed?
Wow, that's a really good question. So as far as taking care of them, you mean when you're in? Yeah, if you can explain the question as far as like not having a vac, like are you?
Like in India, you may not have a vac
Yeah.
available in an Indian hospital, and you get a patient, you got to take.
So
to
like
the
for a delayed closure, I mean, because there are different things you can definitely put it on suction. If you can find a sponge or something like that, even packing the wound, I think, with gauze and having that gauze changed for 5-6 days before closing the skin. I mean, I don't know that study's even been done, but but yeah, I think all of those things should be employed. I think just not hurrying up to close the skin at the same time as you're doing this reconstruction with all the contamination, I think will really help get the results better and get your skin to heal.
All right. And I have another one. Just a thought on Dr. Ramana's question. Is there any situation where you do not use a biological mesh?
Oh yeah, I mean, 85% of my cases are synthetic cases, but these are the very complex, contaminated cases. That's where I use the biologics. Everybody else pretty much gets a synthetic though.
I have a question to Dr. Vedra. What is your approach and what is actually your attitude towards two-stage approach for cases of entero-cutaneous fistulas? Why not repair the fistula first and then 3 weeks after get to solve the reconstruction of the abdominal wall?
Yeah, so I mean, I think you can certainly do that in certain cases. The problem, so going 3 weeks back, we know there's going to be scar tissue and it's going to be hard. And if you make another enterotomy, you have another contaminated case. What's going to happen to the fascia after you've gone in there? I worry about this becoming more of kind of a loss of the main issue. But I think if there's a whole lot of contamination, you can't control it. The patient is not healthy, not optimized. I think using a bridging mesh or anything, like you said, two-staging is totally fine. I have much more of an elective practice, and when these patients come in, like the cases that I showed, most of those can be managed, and you get them ready, and they can even, we've done a lot of Botox preoperatively, in these patients, because even though they have a fistula, you can still inject them, get them ready, get their diabetes controlled, and you can do a one-stage repair, because it's not always guaranteed that second time you come in that it's going to be, an easy case. The other thing is it is more expensive to do a two-stage repair. A piece of biological mesh may be $10,000. Another surgery is $40,000, $50,000, so it's really, if you think about it, a two-stage repair is much more expensive. And it's also from quality of life first standpoint of the patient. If you had a choice for your surgery to be done in one, case versus two, I think most of us would choose one, if it could be done safely. And that's not in everybody, obviously, not in every patient.
Thank you. Yeah.
There's another just remark I want to make. The European Hernia Society published a review in hernia. I think it was in 2018 or early 2019. A review that covered all the papers and studies about the use and benefits of biological meshes. the conclusion was really unanimous, and there was really the sentence I remember from this paper is there is no justification for the use of biological meshes. And this is not a study of one person. It is a review of all the published researches that were published till then.
Well, I think one thing to consider is that there are a lot of different biological meshes from all kinds of animals, from all types of, the way they're processed, the way they're sterilized, all of these meshes are different. So when you take all of them together and then you take all the different techniques and then you take who are we really putting biologic meshes, and these are the worst cases possible. I can see how that data can look really, really bad. But I'm just saying that, if you do have a way to optimize these patients and get them ready for surgery, and you have the expertise of getting this not only reconstructing the GI tract, but also the abdominal wall at the same time, biological meshes can work well in those spaces. And we've done, and certain ones, not just not every single one, because they all perform very differently. So.
Yeah, Pramod Shinde has many questions. So Pramod, try and condense your questions into one. I'm not going to read so many paragraphs. Just go ahead and ask.
Well, essentially, both the talks have been great, Dr. Vedra and Dr. Adarsh. So maybe I can ask one of them is that a lot of discussion around biologics and the permanent synthetic meshes. But now that, the Phasix is also there as a delayed absorbable mesh. So Dr. Vedra, what is your take on using Phasix in a situation where you would have a choice of using either a biologic or a synthetic mesh? But why not use Phasix, which is a delayed absorbable and might give you the benefits of both?
I have a really good answer to that. Well, Phasix never been studied in a contaminated setting whatsoever. We only have one study in humans out right now, a study from Dr. Roth, and they use this in clean cases. These are patients who have a touch of diabetes, or maybe smoker or so. So they are, and they're very small defects, 100 centimeters square defects. So not fistulas, not anything like that. And they have about an 11% recurrence rate already with the Phasix in those cases. So considering that, I would not use them in these cases. The other problem is that most biosynthetics, when they are in contaminated spaces, they act just like a synthetic. They will not go away. So that's the only reason. The other study that Dr. Rosen did using BioA was quite promising, but they are still going to have recurrences that are high. So that would be the only thing. So yeah, I think Phasix in a completely clean case, you can consider it, but in these, I just don't think it's been proven or published, so that wouldn't be something that would even cross my mind and all.
Okay, thank you.
Dr. Vedra, I have a comment on possibly your views on something. Can you hear me?
Yes.
We have a policy in our department that 2 teams operate for such patients. Like one, we believe that we are much better at handling adhesions. We do the abdominal part, we handle the adhesions and all, we finish it off. And the next team comes and reconstructs. I've seen in various workshops when a hernia, don't mean to undermine the importance. When a hernia surgeon does these things, they're not used to it. So many enterotomies occur, things happen. Adhesions have a way. You need to have a strategy to handle these adhesions. There's a certain trick, over years you develop wisdom, you know where to go. So we always have a philosophy that 2 teams operate. We do the adhesiolysis, we put the gut straight, we put everything. Then a second team comes in and does the abdominal wall reconstruction. What are your views on that?
So I absolutely loved your talk, and you know, although I've not met you, I've heard. I don't know if you know Dr. Yekel from the Netherlands. He has a very similar slide where he says closing time is coffee time. So what he also, just like you made the point, that's I think extremely valid, is that we don't give enough importance to the closure of the fascia, and that's why we have so many hernias. You know, because you just did a very big cancer case or whatnot, 6-8 hours, and then you know the resident is closing. So I think that's really, really important. I think your two-team approach is also phenomenal. And I think it should be practiced wherever, you know, whenever possible. And I often will ask my colorectal colleagues if, you know, if I think it's anything, you know, more, you know, or anybody, even HPB, whoever you need, absolutely. Things like that are extremely important. I personally really like to do lice of adhesions. That's something I work with a lot of good colorectal surgeons, and those are my favorite cases. I can sit there with curved mayos and lice, and you know, working from behind. I mean, the retraction. You know, I really enjoy it. So for me, I don't want to give that stuff up because I like it, and I feel like I've developed techniques. But I completely agree with you. In some of these cases, that team approach is really what's going to save the patients. And I like how nicely you put that in your lecture. I think that should be, you know, advertised, and residents need to understand that you're not giving up when you know, let somebody else do it. You're actually going for the win. So.
Thank you.
Yes, Doron.
I agree with the obvious need for prevention of postoperative ventral hernias, and I sympathize with the approach of asking somebody who is really an expert in this field. This is very good. But I think you mentioned, if I'm not mistaken, I heard in your talk that you mentioned the option of using an intra-abdominal mesh as a prevention method for preventing POVH, postoperative ventral hernia. What is your approach? And both Vedra and you, what do you think about an intra-abdominal mesh? As nowadays we try not to use this approach. We try to put the
and
meshes
IPOM
in
is
other
dead,
places.
Doron. Is IPOM dead? One of our colleagues, Dr. Jamma, asks this question. Should we stop using IPOMs?
In my opinion, yes. But very few cases that I use IPOM nowadays. I think most of the cases can be better managed by submuscular personnel approach. In my opinion, there's no question about it. It is almost dead. As you once, I think there was a excellent lecture by Jan Kukleta, if I remember well, that he announced IPOM as a dead method. I think that we need these methods sometimes in very selected cases, but as a prevention method for ventral hernias, I think it is not appropriate. What is your approach?
I was merely looking at studies where they used a dual mesh intraperitoneally, but I agree with you. First of all, the whole concept of prophylactic mesh is a little scary because we haven't identified these patients. I mean, if we could reliably identify, because putting a mesh always is the potential for complication, I agree with you. And I also, like you, I'm scared of intraperitoneal meshes. So I think that paper has to be carefully evaluated, but 169 patients, they're randomized. So I have never used a prophylactic mesh now, but I am beginning to believe that there is a small subgroup where I think a mesh might be indicated. But I agree with you, the scare of an intraperitoneal mesh is too big to be used as prophylaxis.
Vedra,
what do you think?
I think you're taking, you know, these very high risk patients, GI tract reconstructions, and then if you're using a synthetic mesh, I mean, or, you know, it's not going to be good. So it is very scary because we don't know the patients and we don't know the kind of meshes to use. So yeah, I mean, I think it could be a recipe for disaster, but we do know that there's some promising data on using prophylactic mesh. As far as where to put the mesh, if you can put it outside of the abdominal cavity, definitely try that. I wouldn't say that the IPOM is dead because we've really, we're kind of looking at that specific group of patients that have horrible mesh fistulas and things like that. But that doesn't doesn't happen that often. You know, it's still 98% of the patients who have their mesh inside the belly don't develop those fistulas and things like that. So there are a lot of people out there, there's surgeons out there that have IPOM meshes in their belly and they do just fine, you know, because the meshes are different. There's so many different meshes. But yeah, absolutely. If you have the expertise to hide the mesh, you have the time, you know, I think it's a really good thing to do.
Okay.
Rama,
Yeah, Ron?
if you've got time, yeah, I mean, there's some data on, I think from the American hernias quality group about who did and who didn't get enterotomies, and they interrogated the surgeons who didn't get enterotomies, and they came up with 3 factors, and they said that they used sharp dissection, often scalpel dissection. They often left little bits of mesh behind on lips of bowel if they were too difficult to get off. And instead of trying to dissect off difficult areas, they'd actually excise and resect and anastomose, and they had less complications and less likely to get fistulae that way. So there were 3 things, and they're clearly interesting ways of avoiding getting a fistula. And I agree with Vedra that an enterotomy is very bad news, and people who have enterotomies, even if they're closed, always worry that there's going to be a problem somewhere down the track. So avoiding it at all costs is really important.
Right. So,
Dr. Kopelman, the IPOM might be dead in Europe, but it's alive and well elsewhere. That's the problem, or not the problem, I don't know.
incidentally, Rod Jacobs is probably one of the go-to guys for all kinds of messy hernias in Australia. So he has considerable experience in handling all this kind of mess. So anyways, unless anybody has anything specific right now, I think we can close the session. Pramod, do you have anything?
I just wanted to ask Vedra about whether she uses this mechanical irrigation devices with or without antibiotics to minimize the surgical site occurrences after doing these complex cases.
So we do irrigate with like a bacitracin and gentamicin irrigation. So I think there was a study done that actually looked at those pulse irrigators, and they actually traumatized the tissue. So I stopped using that. I did it in residency. So now we just irrigate and hope that the antibiotics will do it. But, you know, I'm sure we need better studies and all that. So,
but I think that the data on topical antibiotics is very, very dicey. I think what works is the mechanical part. You don't have to complicate simplicity. Just take a 50 cc syringe and irrigate. I think that's the best way. You don't need anything sophisticated for that. The data for topical antibiotics in anything is.
I still use the pulse irrigator, the pulse lavage. I like it. You watch those bits of fat float away.
You're a rich man.
And I use a solution containing clindamycin and gentamicin. There's a study out this year or late last year showing that it has a positive effect. You've got to use the right quantity. You've got to leave it in for a long time. It's not just washing. You've got to leave it in for 4 or 5 minutes. It's voodoo probably, but I think every little helps. And I do delayed primary closure. And then after I close the wound, I put a negative pressure wound on as well. So at least then I've used everything I possibly can. If they get a wound infection, they get a wound infection.
If there are 2 different ways to reach the same point, you choose the more expensive one, right? So I support you, Rod.
It's not only that. It's not only that. There are studies that show that using antibiotics irrigation makes the SSI later with more difficult species of bacteria. So I personally don't use antibiotics irrigation. It looks to me as even dangerous, not only expensive.
Well, there is data showing benefit, but then there's not much data. I think Ajita probably published on it, or
Ramana,
Eric Polai was.
The data for topical antibiotics over years has not been able to convincingly prove what you believe doesn't possibly become a fact.
10 minutes में phone करता हूँ meeting.
Right.
So basically the take home message is irrigation is very important, Whether you add it mechanically or whether you would add antibiotics or not is a personal choice, possibly.
There is a randomized trial from Mexico which showed that mechanical wound irrigation just with saline was significantly affected surgical site infection rates.
The same results, yes.
Thank you.
All right, I think we can bid good night and good day to those of you in the US. Thank you very much, and maybe we'll see you again soon.
Thanks,
Thank
everybody.
you, Ram. Thank you, everybody.
Good night, everyone.